And I'll try to go fast as I know we are out of time. So I wanted to talk about laminar fMRI for dystonia. And first of all, I want to acknowledge my collaborators since this is a team effort, especially Renzo Hoover. So dystonia is a debilitated movement disorders that is characterized by construction of the muscles. So typically what we see is when the subjects try to do a particular movement, they can't, but it's not for every action in the hand, is for a particular. This is an extreme case where the patient have problems simply when they write the number 8. So it's a very common activity, very repetitive, the ones that the patients have issues. And what is suspected is that there is a lack of surround inhibition in this disease. The problem is how we can prove, how we can study this surround inhibition. And I'm not going to get into the details on the 3T or PET studies, but we don't have the ability to do a deep understanding of these phenomena. So in the fMRI, we can try to have a subject using a single finger or 2 fingers. We can do similar experiments with TMS and try to understand the inhibition or lack of inhibition in certain areas. We can do PET studies to understand the presence of inhibitory receptors. But we cannot get at the scale of mesoscopic definition to understand the pathology and the mechanisms of focal hand dystonia. So here is a video of the subject. And if you can see here, when the subject tries to tap with the finger, you can see that the pinky starts moving out of position, right? So the patients have the inability of moving a single finger. So when we try to see, to study dystonia and experiments that we typically do on healthy volunteers, the layer fMRI so far have been, before this study, have been done on healthy volunteers. So we start having an extra layer of problems when we try to study these patients. So as I show you here, the possibility of performing the task is one of the problems. Another problem is that when we run studies or try to optimize a technique, we have the semi-professional health volunteers, people that are commonly in the scanner, that are familiar with the scanning and can stay more or less still. We don't have that much time with a patient in terms of adjusting parameters in the scanners. So when we approach this study, we have a setup that is similar to what had been used for layer fMRI in healthy volunteers. But now the big difference is that instead of using many hours of data to get a good resolution of the layer and the columnar information in the motor areas of the brain, we have about 30 minutes. So the questions that we have are whether we can collect relevant data for a patient in 30 minutes, again, compared to the previous study done with the sample sequence, the same scanner, the same task, but we have done, Renzo have done with 10 sessions of 2 hours or 9 sessions of 2 hours each in healthy volunteers. So you have 18 hours of data in comparison to 30 minutes. Then if we can collect data, we wanted to answer whether the finger representation is altered in dystonia and whether we can get a sense of what is the distance between fingers and whether there is a layer effect alter in these patients. So we use vaso signal acquisitions to try to answer and detect the function of the motor cortex in the patients, sensory motor cortex in the patients. So we were able to collect data, right? That's we place our slab on the motor cortex, and we need to go through different processes. This is a typical time series of one of our patients, and as you can see, is contaminated by motion, what makes us work in a very different strategy that you would do in a healthy volunteer. If this was a healthy volunteer, you probably will trash the data and look for a new subject. But this is a very real problem with patients. And what has to be done here is consider each of these chunks as a different acquisition and then do a very tedious registration of these different parts to be able to co-localize. And that requires, on top of the big processing, also having an acquisition large enough to be able to then do the motion correction. I should say that this is collected with the old Siemens scanner. With the new version of the scanner, we probably have the possibility of collecting a higher field of view and a bigger slab. So this could be mitigated a little bit more. I mentioned already the problem, the noise in compliance from the subject. So this, when the subject tried to move one finger, another finger will move as well. And again, that's what in the theory we talk about, like, well, probably is a lack of surrounding vision because we can't block one finger when we move the other. The way that we work to fix this problem is to combine the data, so do some level of integration on the data and look separate when we look at the sensory areas and looking at the localization of the different fingers versus when we are trying to look at the layer fMRI. So what was done in the analysis is we look at the layer smoothing through a different voxels in different columns within the area of interest. And when we look at the columns, we smooth around across the different layers to improve our signal to noise. We also have some artifacts because we to collect this data requires a lot of, I mean, could be improved by a lot of adjustments in the parameters of the scanner to optimize for each individual subject. But if we have a 2-hour block that we can have the patient, and in that we need to consider getting an MPRH, place the subject in the 7T and everything else, we do not have that much more time than the 30 minutes acquisition to play with these parameters. So some of these had to be then optimized post acquisition. And the way to go about it, and you can see in the same subject that those artifacts can be corrected, is to do some dynamic division between the vaso and the EPI signal that is collected at the same time. So we can get decent quality data. We collected in both hemispheres because the patients have one hemisphere that is affected, as I mentioned earlier, is a specific task, and most patients in the dominant hand. So we can use each subject at its comparison when we try to understand the results. When we look at the digit representation, it's clear that on the non-affected hemisphere, we can identify each of the fingers separate. And when we look at the hemisphere with the dystonia affection, we cannot separate the fingers. Really, when the subject tries to move one finger, we get co-activation of areas in the other finger. So we cannot create the differentiation or compare the specific localization. And as I mentioned, we do it across the different cortical layers for this. What is very interesting for us, what was very attractive as the results, is that when we look at the layer, we do see differences between the unaffected hemisphere that has a higher we can see the two bumps, the unaffected, the deeper layers, and then a second bump in the deeper layers. And so the inputs and the outputs have their signal. However, when we look at the affected hemisphere, we see that the signal in the deeper layers is much lower and is very clear in the vaso signal. You can see some of the effect in the ball signal at the layer level, but definitely it's more clean and clear that there is an affection on the deeper layers. And again, this is only data from the motor cortex. So trying to give a few minutes for discussion after this, I just want to say that we can use in patients layer fMRI to explore pathology at the mesoscale level. It requires a lot more care in the post-processing, given that the quality or the possibility to repeat the experiments will be much lower than in the healthy controls. We could not repeat the organization or the difference in finger representation in the affected hand in comparison to the non-affected hand. And this could be a consequence or of the behavior, or could be the cause, right? We can define which one is the first. But what we can say is that the patients with in the hemisphere where they have the focal hand dystonia, we can see that the activity in the motor inputs layers in the layer 2 and 3 have a increased activation and have a reduced activation in the motor output layers. So that supports the idea and probably give us a better understanding on the concept of surround inhibition, because really we can see the inputs and outputs of the activity. And hopefully with the upgrades on the scanners, we will be able to extend this to see the next areas and see how this can be extended to understand where the problems can go and how we can follow the different circuits. So this I would give back a few minutes, and thank you for your attention.
Thank you very much, Dr. Horovitz, for that fantastic lecture. I think we have a few minutes now that we can hopefully have our panelists answer a few questions that have come in from the chat. I'm going to pose one to Dr. Horovitz that just came in, and they're asking, how did you control the head motion during scanning, and what criteria do you use to exclude scans due to head motion? That's a sort of an issue with a lot of fMRI studies, and so we'll be interested to hear what your thoughts are on that.
Yeah, so if you were a 3 Tesla scanning or a regular, a place where we can have a lot of subjects, probably this subject will have been used, right? We don't have that much control. So I would say in a regular fMRI study, we set up a criteria of what percentage of displacement we accept. And then based on the number of regressors that we are going to use for all the physiological noise and other factors, task and such, we will need to have enough degrees of freedom. In this case, we have very few number of subjects. I should say this is only 4 subjects of 4 patients because the scan was upgrade after. And we use every subject. That's make us go the extra step. The reason that we would exclude a patient in this study would be if we ran out of field of view when we're doing the corrections. Because again, we don't have the luxury in other case, but typically the short answer will be you typically go by a percentage of the placement.
Thank you. I think we've got a question directed to Dr. Fagan. And we've heard a lot about parallel trans